Okay, so this patient presents in my office with an abscess around number 8. Here's a couple different looks at it. There's a close-up from the facial. There's a close-up from the lingual. Obviously, you can see the swelling around there. And so what do you have to do with a patient like this? First thing you have to do is take the tooth out, because you got to get that abscess out. And everyone knows that I like doing delayed immediates, putting the patient on antibiotics, getting them back 3 weeks later. But the problem with that is if you do that with the anterior, you're going to lose the gingiva. And in the maxillary anterior, that gingiva is pretty important for aesthetics. So we're going to go ahead and do the immediate today. So you can see I've placed the osteotomy to the palatal in the extraction site, which is what you're always going to do because you want to come out the cingulum. And now what I'm going to do is I place graft material all around here, and then I recreate the osteotomy with a Versaburr, a slow dry and reverse, and then I place the implant into the osteotomy with the graft already in. That way I get a more homogeneous condensation and disbursement of the graft material. So that's what it looks like when you do it. And when you're placing this implant in here, it's going to be 3 millimeters beneath the CEJ of the adjacent teeth. And it's going to be, again, as we discussed, toward the palatal. All right, so this is a custom temporary. What you do is you use his own tooth to make the temporary. And I've shown this several times. There's a close-up of it because the body just loves the natural shape and the feel and the biology of the original tooth, even if it's a crown on there. There it is. You can see that it was indeed a crown, and we had to pretty much destroy the lingual, but then we just rebuilt it with composite. That's what it looks like on the facial. All right, so a week later, this is what this patient's going to look like. Looking quite a bit better. You see how the papilla are still there? That's why you take the risk of dealing with the infection. This is the one place that I'll do this because it's worth it to keep the papilla there in the maxillary anterior. And again, there's the palatal. So then we're going to get them back. This is now like 1 month post-op. Let's see what it looks like now. Very nice. The tissue's still there. The gingival architecture's there. All right, now we're here about 2 months later, and that's still looking really good. Look at that. Once it gets nice and stable, then you can take your final impression, get the final restoration, and this is the final restoration, so that's looking pretty good. And because we did all that fine work with training the gingiva, we still have the gingiva there. That's a very nice outcome. There's a nice little close-up for you. I think you can agree that's pretty good work. So here is your pre-op radiograph. As you can see, the patient's got a little bit of an abscess here. The other thing the patient has is a ton of bone. Thank you, Jesus. We like that. So what I'm doing here is I'm planning out the case virtually. I think that the more you plan these cases out, the more you think them through before the surgery, the better the surgery will go. So what I want to do is I want to come out here toward the lingual, as I told you. So I'm setting up my implant to come out this way, and I also want it to bite into some decent bone down here. This is one of the times when I'll use a longer implant, is with immediates. Now here's a guide pin shot. On a guide pin shot, you do not want to go into the extraction site and go right out the apex, because you're also going to go right out the buccal, because they're almost always buccally situated. God gets away with that. We don't. So you're always going to come up the lingual wall and put it in here. And I tell everyone for the guide pin shot, try and stay nice and safe. Stay right in the middle, and then you can change the angulation subtly after that with just a little bit of hand pressure, as you're going to see with the final restoration. Notice this one. This one's right dead center of the bone, and the final restoration is a little bit more palatally situated as far as its exit point, but that's what you want. You want to be coming out the cingulum. So this is perfect placement, and look how that's biting right there into some good bone all the way down. This has great stability, and look at that grafting technique that I showed you by putting the bone in first and then using a Versaburr in reverse, slow dry in reverse. Look how nice and packed that bone is. I get great results with this. Now, if you want to be able to do cases like this, and you're out there and you're just starting in implant dentistry, this is what you need to do. You need to join the American Academy of Implant Dentistry. That's what I did early on. That's who taught me more than anyone else, from going to all these meetings and have so many great mentors. And this is just a fantastic organization. As you can see, it's the oldest, it's the best. Go ahead and click on the QR code or the link and join the American Academy of Implant Dentistry if you want to be able to do cases, learn to do cases like this. The other organization that I want you to join is the American Independent Dental Alliance. What is that? It's an organization that's focused on helping offices remain independent, quality focused, profitable, and competitive with the larger DSOs. What does that mean? Look, it's not a level playing field out there. The big DSOs can do this. They're better financially, but I don't think they're necessarily better dentally for the patient. I just don't believe that. I think an independent dentist making his own decisions for the best treatment for this patient is better than a corporation doing it. So I believe strong in them, and this is the QR code and the website if you want to go to that. This is Mike Wehrle, and thank you for joining me on our shared implant journey.